How does the macular edema develops? It is increased venous and capillary pressure, reduces the blood flow, hypoxia of the drain retina, endothelial damage and death of capillaries, increases the capillary leakage into the extracellular space, which increases the expression of VEGF and it triggers the inflammatory mediators, again causes the VEGF expression. It can lead on to macular edema. On the other hand, neovascularization of the disc angle and iris. Non-ischemic accounts for 75 to 80% of all patients of CRVO. They can present with blurred vision, transient loss of vision, wide variation in the vision loss. They have a better initial and final visual outcome than the ischemic eyes. Major vision threatening complications are chronic macular edema and conversion to ischemia in 1/3 of the cases over 3 years. Ischemic CRVO, whenever there is more than 10 disc diameter of retinal non-perfusion defined on an intravenous fluorescein angiogram, we call it as ischemic. Severe loss of vision in up to 90% of patients if left untreated. Pupils fail to respond. Pain can be from neovascular glaucoma. So how do you differentiate non-ischemic from ischemic? By a clinical examination, fundoscopy, fundal photographies, and retinal fluorescein angiogram, which shows more than 10 disc diameter of capillary non-perfusion. Ischemic CRVO can have neovascularization of the posterior segment, anterior segment. Neovascular glaucoma, which generally happens at the month, which is called 100-day glaucoma, permanent changes in the macula and loss of vision. HCRVO is a clinical variant of CRVO, management similar to CRVOs. The complications are macular edema. You can see a non-ischemic or the ischemic can develop macular edema as shown. Other complications could be a hemorrhage, tractional retinal detachment, or angle and iris neovascularization and neovascular glaucoma. How do you diagnose them? Doing a complete ocular examination, fluorescein angiography. The other ancillary tests include the perimetry, pupillometry, ERGs, where B/A ratio is less than 1 in ischemic vein occlusions. We address the treatment or the management is addressed at the edema, ischemia, and neovascularization, and the other underlying factors like hypertension, high cholesterol, other causes of underlying pathology. We also have to remember the long-term management in high-risk population because they are more prone for cerebrovascular accidents, strokes, cardiovascular events, and the renal dysfunction. So whatever the long-term safety profile of any treatment is the key consideration for any treating physician. What is the role of emergency? There is no specific emergency department role in as indicated as lights and siren emergency. Because of the potential of permanent vision loss, no patient should leave the emergency department without a sound and specific plan for urgent ophthalmic consultation. A systemic review of multiple small randomized trials of antithrombotic and antithrombolytic agents, including aspirin, Plavix, heparin, TPA, found limited or no benefit in RVOs. So currently there is not enough evidence to recommend the routine use of antithrombotics in RVO. What are the risk factors? Others, hypertension, diabetes, all these, especially in a young patient, we have to treat hyperhomocystinemia if it is more. These are the set of investigations we would often include in our test or refer it to a patient for a complete evaluation. What's the role of VEGF? It is often shown on an anterior chamber tab and a vitreous tab. There is an increased level of VEGF in CRVO and BRVO patients. This is the highest, in fact it is more than the diabetic retinopathy. Ischemic damage to the retina stimulates increased VEGF production in the vitreous cavity. Is there a role of inflammation? Yes, it can be from the, it can trigger the upregulation of inflammatory mediators and worsening of vascular permeability, prompting fluid accumulation and macular edema. What is the treatment algorithm for a CRVO? Identify if underlying systemic disease exists. Refer it to physician for the better treatment of these medical conditions. Assess level of ischemia by pupillary defect test, clinical evaluation, pupillometry, intravenous fluorescein angiogram. Identify life-threatening sight-threatening complications like neovascularization of the iris retina by gonioscopy. monitor vision retinal examination by microscopy and biomicroscopy and OCT. If it is non-ischemic, monitor first, second and third month, and then every 2 months for the first year. Look for the conversion of ischemic, non-ischemic to ischemic by visual acuity, biomicroscopy, OCT, plus or minus fluorescein angiography. If the vision is less than 20/40, assess for the macular evidence of macular edema, consider intravitreal anti-VEGF or steroids. On the other hand, ischemic CRVOs, look for the macular perfusion. If the macula is perfused, if evidence of macular edema, consider intravitreal anti-VEGF or the steroids. Macular is ischemic, consider intravitreal VEGF or steroids along with the panretinal photocoagulation. If there is neovascularization of immediate anti-VEGF followed by a panretinal photocoagulation. So what are the treatment options we have? Intravitreal anti-VEGF, intravitreal steroids. For theoretical reasons, laser anastomosis to treat macular edema, surgical treatment of by fast parametrectomy with iLuPRI, or radial optic neurotomy. Ranibizumab was established the first line of treatment for both BRVO and CRVO. There are many clinical studies which have gone through. The first of all was the cruise, and the extension of open extension of cruise was horizon. Horizon ranibizumab provides a sustained 24-month response, increase in visual gains in central retinal vein occlusion. Retain, where it is treated as ranibizumab as treated as treat and extend, led to a sustained gains in best corrected visual acuity at 4 years. Showed ranibizumab used as PRN, flexible dosing of ranibizumab showed improving the visual acuity in both the CRVO and PRVO. On the other hand, Copernicus and Galileo, done in both North America, Europe and Australia, showed significant improvement in visual acuity and central retinal thickness from the baseline. So it demonstrated aflibercept solution for intravitreal injection results in rapid and sustained gain in visual acuity. There could be many stages. We often see the responses to be either a good response, that is where we all want our RVO patients to be, or it could be a good anatomic response with a good visual response with a macula being wet, or it could be a chronic macular edema with non-response. It is called a refractory macular edema. The anti-VEGF should be maximizing benefit, reducing the burden. If it is too often, it causes too high over treatment or unnecessary burden on the patients as well as the healthcare system, whereas low, it can cause a suboptimal efficacy. This is how it can be treated. When to stop, switching the agents, there is lack of evidence suggesting there is a switch. Ranibizumab and aflibercept demonstrated similar outcomes in many of the retrospective studies, both in Europe, US, and bevacizumab is only theoretical. The CRVO study on radial optic neurotomy showed insignificant or it's not a sustained improvement in all the cases. Other studies have shown a high rate of complications. BRVO, initially it's the medical care, referring to the medical team. Laser photocoagulation has been a standard of treatment in the past. Recently it is the anti-VEGF, steroids, and there are many other clinical trials which show that steroids could be the first line of treatment. So in summary, intervention for CRVO, you have a list of drugs, mainly it starts with anti-VEGF steroids. On the other hand, for BRVO, it is again anti-VEGF steroids. Laser photocoagulation is the treatment of choice for the neovascularization secondary to RVOs. Thank you for your patience.